Welcome, and thank you very much for watching this presentation. I'm going to talk to you about Torbay Chart Patient Decision Aid System. The talk is divided into three segments: a brief overview of shared decision making process, SDM, and patient decision aid, PDAs, followed by what Torbay Chart system can bring to the SDM conversation, and the last section of how we have translated this to COVID-19 chart. Before I go any further, I would like to thank Dr. Matt Hawks and the HCI team for supporting me in this journey for the last 3 years. Shared decision making is a process in which the patient reviews all the treatment options available and actively participates with the healthcare professional in reaching that decision. This is beautifully captured in the phrase, "No decision about me without me," in the seminal Kingsford article written nearly a decade ago. Reaching this decision happens via an open dialogue between the healthcare professional and the patient. Usually relies on communication skills of the HCP to address the ideas, concerns, and expectations of the patient, and to some extent of their own. The tool that bridges this gap here is Patient Decision Aid, or PDA for short. So what do PDAs do? PDAs should present appropriate choices to the patient and allow true deliberation of those choices. By using a well-designed PDA, we empower the patient, respect their autonomy, improve their knowledge, and make them feel included in the decision-making process. To me, this allows the patients to have ownership in their decision reached, and therefore it is likely to improve their compliance, have less regret, and complain less. We also know that the well-informed patient will choose less invasive option, which is usually less expensive. A recent study from MIT Boston showed that the surgical rates could be as low as 15.4% reduction in joint replacement when the decision aids are used, and this complements with the various reports previously published, including the Cochrane review. So what are the types of PDAs, and do different types equally work well? PDAs may be short with few pages or long running into 50 pages, or there can be a long video. But the study from Boston again showed that the short PDAs are in fact very effective, and if anything, patients have better knowledge score after their use. Therefore, it is no wonder that short PDAs are very popular. Here I present an assortment of short PDAs focusing on knee arthritis decision aids. These include option grids, brief decision aid, NHS England's decision aid, and University of Ottawa's decision aid, which is now linked into NICE's website. Is there a need for a new decision aid? NICE Evidence Review for Decision Aid recently published their final document in June 2020. In that, they reiterate the PDA should not be information giving tools alone, and that they should present information in a way that it is easy for people to understand. They could not recommend any particular PDA as they felt none in the market met their expectation for being a comprehensive decision aid. So what are the negatives of the current decision aid? These are my views. They are impractical to use during routine consultation. They are not comprehensive. They lack relevance and present information without any layering. They could be visually unattractive and do not cater for different learning styles. Most of them are paper-based and have fixed choices to discuss. And generally, they do not allow self-directed comparison. And when self-directed comparison is actually introduced, then it becomes expensive due to the subscription requirement. More importantly, most of the popular and promoted PDAs are not locally developed and cater for the North American market. Now let's go to the nuts and bolts of the Torbay Chart PDA system. Torbay Chart is a revolutionary new tool in the aid of SDM conversation. It approaches the situation in a completely unique way. There are three key unique selling points for the Torbay chart. Number one, overview of the entire journey. Number two, presenting relevant treatments. And number three, a self-directed comparison. How does this do that? Torbay chart is a multi-layer, multi-formatted, visually appealing tool. The layer 1 for the knee arthritis is displayed here. This gives an index of different treatment options placed appropriately to the stage of the disease. Here we have displayed 19 different treatment options for the management of knee arthritis. It is presented in a single sheet and will be the focal point of discussion during consultation. This is like an overview map of the entire journey for the patient, and they can pin some waypoints en route where they can camp and go through that particular treatment. Let me take you through the three USPs of the Torbay chart one by one. Layer 1 gives the patient a drone view of the entire disease and different treatment options. It allows one to diagnose the condition and stage the disease so that appropriate treatment options will be displayed. It is important that without making a correct diagnosis, wrong treatment can be embarked. We all know that sometimes patients present with knee pain with a normal knee, but this may be due to referred pain coming from the hip arthritis. Layer 1 is divided into three segments. The top captures the patient-reported problems like pain, mobility, and limitations of activities of daily living, and clinicians' finding. Combining this will give the stage of the disease. It will prime the patient to consider and deliberate on different but relevant choices. The middle section captures the treatment that are commonly available. Each treatment option spans different widths based on their efficacy. Many treatments overlap with each other. It starts with self-help treatment, which the patient can seek on their own or via social prescription without burdening the NHS resources too much. After the exhaustion of the non-operative methods, surgical options are presented. Please note that the treatment overlaps and spans different widths and are only indication. The last section captures treatment with less evidence or those that are not offered in the NHS, but they do find a place in the nicest documentation. The second key USP of the Torbay chart is offering patients the treatment choices of relevance. Let me show you this with an example. Let's look at two different patients. Patient A enters the journey at an early stage with minimal symptoms and little intrusion in the activities of daily living. His options are available as shown per the vertical arrow. His choices are simple self-help to perhaps some alternative treatment. Whereas patient B enters the scene much later and has advanced disease. His choices are now limited and has to consider knee replacement surgery as one of the main options. A lot of patients fall in between these and they can subsequently move to different treatments both forward or backward depending upon their symptom progress. The third USP of the Torbay chart is the ability for the patients to choose and compare any treatment against any other. Here the patients can self-select different treatments and compare them side by side. Domains of comparisons include risks, benefits, burden, and uniquely we also display the cost of each treatment for the NHS. Let's now watch a video to understand this better. So let me continue with my presentation. So the progress so far, what have I done in the last 3 years? I first presented the Torbay chart concept to the National SDM meeting in Exeter nearly 3 years ago, where Professor Collins was the main speaker. Following this, I visited him in London, and I believe he was struck by the simplicity and the unique approach of the Torbay chart and encouraged me to continue the work and gather evidence. With the help of a local CCG, I was able to tap into the expert patient panel and presented this to 2 different patient panels in Exeter and Barnstable and received good reception. Through the Southwest Academic Health Service Network, I presented this to the patient expert panel, who also gave excellent feedback with very little suggestions for changing. I subsequently presented this at Devon STP Clinical Cabinet and received their approval to pilot this in all regional hospitals. I also presented this to the SDM collaboration in Taunton, where it was very well received, and in fact, the Bristol and South Gloucester CCG and later Kurnow CCG all wanted to pilot this in their own pathways. I also presented this in 2 international meetings, one in Jönköping in Sweden, the other one in Quebec in Canada. In the 10th International SDM Conference, this was critically appraised and appreciated by Professor O'Connor, who spent more than 2 hours exclusively with me to explore how this could be promoted further. Professor O'Connor was recently admitted into Canadian Medical Hall of Fame for her work in shared decision making. My next step is to scale this up and spread this further along to different regions. Following the approval by the Devon STP, we have approached the physiotherapists in Barnstable, Exeter and Derriford to use this in their pathway. In our region, the pathway is set up such that the patient's first point of call is the physiotherapist. We've also are running a pilot in a large GP practice in St. Austell, Cornwall. As mentioned before, Bristol CCG and we're going to start, or we're at the verge of starting, a trial with the Torbay chart. The pilot was good to go, but was unfortunately COVIDized. We are now creating a repository for Torbay charts with 3 shoulder conditions and low back pain. Layer 1 for elbow tendinitis is already complete, and we are exploring possibility of creating Torbay charts for medical conditions like blood pressure management and cholesterol management. We were aware of the NHS England procurement bid for paper version of the PDA tool. We did place a bid, but we felt that the total experience for the patient would be far superior if all the components of the information and comparisons is available on the web. Also, we could not unlearn what we learned about the concept of Torbay chart and how well this was received with our patients. I will very briefly now cover the results of a pilot test done in 3 different places. They were all done in different time scales. We assessed the benefit of the use of Torbay chart with a questionnaire and had 3 simple questions. The most important question, however, were if the patients were able to appreciate different options available and whether the Torbay chart supported the shared decision-making conversation. In Torbay, 100 out of 107 patients gave a score of 8 or more out of 10 for both questions. In North Devon, 11 out of 14 patients gave a score of 8 or more out of 10 for the same 2 questions. And in Derriford, 31 out of 36 patients gave a score of 8 or more out of 10. In this pilot, a lot of patients obviously did choose non-operative treatment, which is not surprising. However, the most important thing we found was about 7.4% of patients who came in expecting to be listed for an operation chose non-operative treatment after using Torbay chart. This was translated, or if this was translated into NJR figures, with a modest 2% surgery avoidance rate, one could postulate a savings of £26 million per year. Could Torbay chart be used to our advantage in the post-COVID situation? I think there are a couple of important uses. One is waiting list validation, and the other is reappraisal of patient choices. We are looking into some practical ways of contacting patients who are already on the waiting list to see if they would consider alternative choices if appropriate. Given the fact that in Derriford nearly 80% of patients chose non-operative treatment in the first trial, there may be few on the waiting list who are at the borderline and might wish to try non-operative treatment until the COVID situation resolves. Now let's move on to the COVID chart. We all know the importance of decision aid and delivery of patient-centered care in other conditions, but so far I have not come across a decision aid or an educational aid for COVID-19. To begin with this, is there a need for a decision aid? Patients get their information from reliable websites like gov.uk, Public Health England, NHSE, etc. But navigating these websites could be rather challenging for many patients. Allow me to discuss few things with you. First of all, let's watch this short video clip from BBC.
About a day ago, I had a notification that says that I've been near someone who has coronavirus symptoms. It said, read what to do next, and then follow this advice until the 2nd of June. When you tap on it, what you get is the basic government, if you can see that, the basic government guidelines for everybody. So there was no talk about self-isolation for 7 days, just following the basic requirements, which I'm already doing.
Yeah, I imagine after all these weeks, you could almost recite them off the top of your head.
Pretty much, yes.
What would you have expected to have been told?
I would have expected to have been told to self-isolate for 7 days.
This lady expresses her frustration of not knowing what to do next. And more importantly, she got the self-isolation duration wrong, for she said self-isolation was for 7 days, unless obviously she had symptoms. I would also like to share a couple of stories. One of my colleagues' family member became breathless and fainted at home. She was diagnosed to have COVID infection but was told to go home as she did not meet the criteria for admission. They were sent home with some basic instructions only and were asked to return back if things got worse. They were very concerned as they did not know what could be done to mitigate their illness and how to monitor things at home and when to trigger the call back again. My second colleague's son returned back from university in Madrid just before the lockdown. He was not symptomatic but had come from a place where there was COVID infection. My colleague found it very difficult to wade through the maze of information that was available from authoritative websites, but still could not find an answer regarding the rules of self-isolation for the family in that situation. Therefore, confusion abounds. So what we really need is some sort of Rosetta Stone that will translate the complicated and heavily loaded information in the various websites into a simpler form where one can navigate sensibly and learn about self-care and various other information that matters to them. This is where the philosophy of the Torbay chart could be applied and could help the patient and their healthcare practitioners. Here is the Torbay chart for COVID-19. This is not the final version. Following the DNA of the Torbay chart, COVID chart has 3 segments. The top segment captures the patient-reported symptoms and the clinical findings. It reassures the patients that 80% of them will have no or mild symptoms only. The middle segment is predominantly focused on self-help and groups the important instructions into 6 sensible and logical action groups which the patients can follow. It then groups how one could self-monitor at home and what are the red flag signs one should look out for in order to decide when to seek further help. The third segment gives them less established and poorly evidenced treatment. Deeper layer simplifies the information from the authoritative sources like gov.uk, Public Health England, etc. enables public to navigate that information. Additionally, we've actually included some good self-help guidelines, especially for home monitoring. This can help a lot of patients. It provides a single point of access to all relevant information and places them in a logical fashion for easy navigation, and therefore the patients can process that information better. The strength of the chart is that it can support patients who are symptomatic to be confident enough to self-care, but also provide guidance on when to seek help. It can help the healthcare professional, GPs, and potentially NHS 111 team to provide remote guidance to patients. I see a lot of value for everyone who could use this as a lexicon to decipher the plethora of information that patient gets bombarded with regarding COVID. The concept of Torbay chart COVID chart and the website has been demonstrated to a Trust Senior Clinical Management Group, which includes GP champions, and this was very well received. I also presented this to the Southwest Academic Health Science Network's Expert Patient Panel Advisory Group and received excellent feedback from all the 12 patient experts. We are at a stage where if there's enough interest, we could develop this further. What we need to do is to create awareness for the existence of the concept of Torbay chart PDA system, and this would allow the spread of the concept wider. Even the best of the best products will not reach many if there is no awareness. Without creating this awareness, even we will not be able to promote this further. We have additional ideas, including things that could be done here. For example, here is an animation video.
What is social distancing and why should we practice it? If you are infected with the virus, you will shed it when you sneeze, cough, or talk loudly. The virus can travel for a distance in a droplet. It can then spread to a person directly, or the droplets may fall on objects used daily. A person may catch the infection from these. If you are standing close to a person, then you can easily spread this in a droplet. However, if you stand at a reasonable distance, then this transmission is minimized.
Continuing with the presentation, the Torbay chart has been developed in collaboration with the Trust Partnership Venture with the Healthcare and Video Innovations. HCI have partnered with the NHSX regarding their video library now, and the HCI team have been with me for the last 3 years developing the Torbay chart. If time permits, I'm happy to do a brief demonstration of the website. Thank you.